Coming up on the program, our healthcare experts discuss the latest in medical news, and then they answer your questions.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at americanbrainfoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
Hi, I'm Dr. Joe Servin, a practicing neurologist at Mayo Clinic and professor of healthcare administration and policy at Arizona State University. This is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Coming up, it's our monthly medical roundtable, and we are talking the biggest health headlines from the past month, ranging from new antibiotics, new cholesterol lowering and blood pressure meds, plus another reason to get the shingles vaccine, and why is choline important. Then our experts answer your questions. But first, April was another busy month, judging by the topics that dominated health headlines. We're talking about new antibiotics, the latest cholesterol and blood pressure meds, older women having kids, and another good reason to get your shingles shot, and why choline might be more important than you may believe. Joining us to talk about all of these topics are Dr. Amy Hessler. She is a practicing neurologist here in Jacksonville, Florida. Dr. Hessler, welcome.
Thanks, Dr. Servin. I'm glad to be here as always.
We love having you here. Dr. Dacre Knight, he is a practicing internist. He's head of the Ehlers-Danlos Clinic at Mayo Clinic in Florida. Dr. Knight, welcome back.
Thank you. Always glad to be here. Thank you so much.
It's so good to have you here. And we have Dr. Donna G. Ivory. She's an OBGYN podcast host, author, and we're so happy to have Dr. Ivory back with us. Hi, welcome back, Donna.
Dr. Servin, you know I love being here. Thank you so much.
We love having you here too. We're going to get right into it. And our first topic is a one-dose drug that shows promise in lowering bad cholesterol. Dr. Knight, we're going to point this one at you. In a clinical trial conducted by Novartis and presented at a conference of the American College of Cardiology, an experimental drug called lepodisiran was shown to reduce levels of lipoprotein A, or LPA, by up to 94% with just a single injection. Now, LP, short for lipoprotein A, is a type of cholesterol that's been difficult to treat until now. These results are creating excitement among cardiologists, primary care physicians, but what could it mean for everybody else? Dr. Knight, what is LPA or lipoprotein A, and walk us through how is this different from LDL cholesterol or HDL cholesterol that we typically hear when we get our blood test for lipids?
Well, that's a good place to start, I think, because there's, yes, as you pointed out, lots of excitement around this. It is quite a breakthrough, and really these types of drugs in this area of heart disease, really a sort of a holy grail of sorts, because also, as you mentioned, we don't have a drug to reduce lipoprotein A. So what is that, as you asked? So lipoprotein A is a type of cholesterol. Yes, we hear about different types of cholesterol, good cholesterol, bad cholesterol. So we usually compare like the bad cholesterol's LDL to that. And LDL is more pervasive throughout the body. And yes, there's certainly a risk of atherogenesis, meaning blockages in the heart arteries that can cause heart disease from LDL. But we actually know that this type of bad cholesterol, lipoprotein A, is essentially the same thing as LDL, except it's got an extra protein attached to it. And that's where the A comes into it. is actually even more atherogenic. So it is actually more directly linked to heart disease and causing blockages in this atherosclerosis buildup. There's not as much of it, so that's why we don't hear about it as much. But if there are elevated levels, it's been reported that there is increased risk of heart attacks and cardiac events. So that's the difference between LDL and lipoprotein A. So they're both bad, so to speak. One is more common, the LDL, but the lipoprotein A can actually be more harmful directly.
So, how significant are these early results?
Well, these are huge. Yeah, and it's not a done deal, of course, because
Sure.
this is the kind of the phases we go through in drug development, and so this is now just phase 2. But it is quite a breakthrough because we don't have any medications to reduce lipoprotein A, which we know can have a very direct, severe atherogenic effect, meaning causing atherosclerosis. And there's nothing there. So you can take statins, you can do exercise, you can eat right, and it may not it will likely not reduce your lipoprotein A. So having something that can is tremendous breakthrough. We just need to kind of go through all the stages of drug development to make it more widely available.
If this becomes approved, a one dose treatment, is this, if that were to become approved with this type of number holding up, is this a game changer then?
Oh yeah, absolutely, and that's where we are now in these studies. So understanding what is kind of the long-term effects, and so those are the kind of the final phases of drug discovery and drug implementation, and then also knowing how many doses, as authors pointed out in this study, that there is still some uncertainty maybe, and we do know, for example, some populations like Black patients have higher risk of elevated lipoprotein A, so that group may need to be studied more specifically. But also knowing what are subsequent doses going to do. Is it going to hold up? And then also a bigger question is, actually having this reduction in lipoprotein A actually going to reduce cardiac events.
Yeah.
Right now it's conjecture because we know elevated lipoprotein A can be related to having increased risk, but does that mean lowering, and by how much lower are we going to need to get it to know that we're going to have those real good benefits of the drug?
I guess that means stay tuned, and we're going to pivot to another topic. Dr. Ivory, I'm going to point this one at you. It's also a first in its class. A new antibiotic for urinary tract infections was approved in nearly 30 years. The FDA approved penicillinum, a new antibiotic for urinary tract infections, the first approval in 30 years, as I mentioned. It's already been used in Europe for decades, but this drug is seen as a welcome tool to combat antibiotic-resistant infections, which are becoming harder to treat with existing antibiotics. Dr. Ivory, I guess a simple question. Why has it taken 30 years to get a new UTI antibiotic approved in the United States?
Dr. Joe, it's amazing. It's probably just timing.
Yeah.
If you think about 30 years ago, floxins like ciprofloxacin, the other medicine, nitrofurantoin, which is macrobid, and Bactrim, those things were extremely effective when it comes to UTI treatment. We also look at this particular drug. It's not quite as good as those drugs were, and it has a few extra side effects. So I think there are a combination of things that were going on. And then we always talk about the penicillin resistance in the US, which we think is really only about 1%, but that's still about 3 million people. So I think it's a combination of timing and those issues, but it's been used in Europe for 40 years.
Yeah.
And so the information coming out of Europe has been that in that 40-year usage, we're not seeing increased antibiotic resistance to this particular antibiotic. Now, many UTIs are resistant to macrobid, are resistant to Bactrim, are resistant to floxins. So we're starting to run out of routine medications, especially with recurrent UTIs. And this medication with 40 years of usage hasn't shown increased resistance. That's why they've come back around and looked at this one.
How does this new medication work? Is it different from the antibiotics and how it works?
Well, slightly. It's a penicillin, so when it's active, it works in a similar manner. It attaches to a different protein with regard to bacteria. So it is unique amongst the penicillins, but it's an inactive form of penicillin when it's taken in. So you take it orally, is then activated, and then 80% of the active component methicillin is then available in the urine. And the efficacy, the effectiveness is very, very close to the older medications. So if we think of Floxin and Bactrim and Macrobid as having 80 to 90% efficacy, this medication may have 70 to 80% efficacy. But if you've got 30 and 40% antibiotic resistance rates with our older medicines, then this medicine, especially in the setting of the antibiotic resistant bacteria, looks far more promising and far more useful.
I'm going to ask you a similar question I asked Dr. Knight about the cholesterol lowering drug. Is this drug becoming approved a big deal?
I think so. If you remember, the number one reason that women go to the doctor is UTI.
Oh, yeah.
So UTIs are a big issue in medicine. And then when we start looking at recurrent UTIs, the antibiotic resistance aspect is becoming so bad. We're starting to have women and patients who need to be hospitalized or need to have physical procedures to address a persistent antibiotic resistant infection. And so having something that would work, that is oral, that should be affordable and readily available and pretty easily tolerated, that means everything. And if this is one that really is resistant to bacteria becoming resistant to it, that's a game changer. So I think it's a huge deal.
We'll see how this turns out. We're going to pivot to yet another topic. The shingles vaccine made headlines in that it was found in a study that it may lower the dementia risk. Dr. Hessler, this one we're going to point to you. In a study funded by the United Kingdom's National Health Service and published in the journal Neurology, researchers found that people who received the shingles vaccine were up to 30% less likely to develop dementia. Now, the connection isn't fully understood. The theory is that reducing inflammation from viral infections like shingles may offer some protection for the brain. Dr. Hessler, I kind of put out what the author said, but I'll ask you, how might preventing shingles potentially reduce the risk of developing a dementia?
So, Joe, this is an exciting study, actually, and I reviewed it in detail, looking, in anticipation of talking about it today, because I wasn't that familiar with it. But really, this looked at 280,000 adults in Wales back in 2013. And basically, it was what was called a natural experiment, and that people were 80 years or older were not eligible for the vaccine. And that's just how the country of Wales just rolled this out. And then those less than 80 were eligible for the vaccine. And the fact that they followed these patients, these people longitudinally, and that 20 to 30% didn't get, that had less occurrence of dementia, I think is, as you just asked our other two guests, is exciting. So the author said this is looking to do a large randomized controlled study because this was a natural experiment, if you will. But the fact that it's in the field of prevention, I mean, actually, when I first saw it, I thought it had to be too good to be true. Yeah. But, because it felt like, how could we, too good to be true? Because as I tell my patients, we can't change our family history. We can't change our age. And I myself, as a neurologist, have a family history of Alzheimer's, dementia, and I see a lot of patients that are very scared of losing their identity as they get older. So the fact that something could proactively prevent, I think I've been on your show before and we've talked about these new treatments, but something we could do to prevent is actually pretty exciting. Now, as far as the mechanisms of how it works, it's not really well understood. Yeah. It could be the protective effect of the vaccine. change, and the authors had gone into, could change, how people are in the healthcare pathway, reduction in that reactivation of the varicella zoster virus. So I'm in midlife, and I had chickenpox. I think, we all got lined up and exposed because we wanted to do chickenpox as, to get it done with. But now we actually have a chickenpox vaccine that actually my children, who are now teens, got, so they never had chickenpox. So the question is, is this next generation and subsequent generations younger than I am, now being protected? So, because what happens is this virus lays dormant, and then later in life, after one has had chickenpox in childhood, presumably, obviously adults can get chickenpox, but presumably in childhood, and then later on, it can get reactivated, and then and we call that shingles. So when people have that later on, so again, I read this thinking it was too good to be true, but I guess time will tell, and doing a large randomized control study will help us get some more information that we really need.
Dr. Hessler, if to those who might be on the fence about getting the shingles vaccine, what does this study mean for them? Well, what would you suggest to them?
So the shingles vaccine, one could think that the shingles vaccine could potentially go beyond not just getting a shingles rash. And then, and as neurologists, we sometimes see people get what's called a post-herpetic neuralgia. It's a pain condition that unfortunately can be chronic. But now there might be another reason to consider getting a shingles vaccine if this does play out, that it can be beneficial. And again, I think this natural history might be a little too early to make, wide sweeping generalizations. And I think we need more study and more data. But, as compared to treating a disease after it's happened, something that we can proactively do is pretty exciting.
I so agree with you. And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin. And if you're just joining us, it's our monthly medical roundtable. We want to hear from you. Tag us on social media at JServin. We're going to go to yet another topic, another positive new class of medication. And Dr. Knight, we're going to point this one at you. There's a new blood pressure drug that helps people with uncontrolled hypertension. Again, the same meeting at the American College of Cardiology conference, a clinical trial that was presented there showed that a new blood pressure drug called zilebesiran helped patients with treatment-resistant hypertension, and it achieved meaningful reductions in blood pressure. This is for people already taking multiple medications with little effect. This could be a huge option or a promising one. Dr. Knight, what makes this new blood pressure drug different from the ones that are already on the market? Because there are so many others on the market.
There certainly are, Joe, and I should say it must have been pretty exciting to be at this conference.
Yes, I know everything came out of it.
Yeah, so much to discuss. They all must have had their heads buzzing going home, but but it's exciting for us in clinical practice to be able to put these tools to use, because what do we have if it's non-surgical medical treatment? It's medication and education, as we say. And certainly when we're discussing about blood pressure and heart disease, I mean, heart disease is the number one killer in the United States. So any of these things that we're making progress on are a real boon to longevity, quality of life, and everything, and healthcare costs and all of it. So this new class of drugs, so in particular, the lorundrostat, is the one we're talking about now, is interesting. So all of these blood pressure drugs have just slight different mechanisms. There's lots of things that can raise blood pressure. Right. So it's the kind of the kidney's role in adjusting that, but there's different chemicals and hormones that the kidney excretes to do that. And so if we can manipulate any of those, then we can get blood pressure control. Of course, there's also side effects because we, turn one thing up, something else goes down, whether it's sodium levels or potassium or electrolytes. So having another tool in our toolkit is really useful, just based on what is each individual patient condition we're working with.
Is uncontrolled blood pressure, uncontrolled hypertension a big concern, for them to generate yet new medications for this?
It is, and it may not be something that a younger clinician would think of at first, but high blood pressure is very common. And among those patients who take medications for high blood pressure, getting actual good blood pressure just from one medication or from just one treatment modality is not usually effective to get right down where we want it. So it may require more than one medication. So when we call it uncontrolled hypertension or resistant hypertension, it's basically uncontrolled high blood pressure. And when we're talking about high blood pressure, we're usually talking about that top number being more than 140. And so getting it down to an ideal goal, and of course every patient is a little bit different. It can take a lot of manipulation with different drugs, and it can be quite tricky. So that's where anything added to help with that is going to be really useful.
I'm going to ask you the same question I asked you and also Dr. Ivory. Very similar vein. It's a new headline, a new class of drug. Is this a big deal?
Well, it is. I mean, we still have to see, as we were talking about these other newer medications, how it all plays out. Because, ultimately, we look at numbers, we look at cholesterol levels, we look at blood pressure numbers, and, it's great we can manipulate those, but what is the actual effect on the patient? What are the benefits to outcomes? This particular medication, we have to be careful because the way it works is actually reducing the synthesis or creation of a hormone called aldosterone. And aldosterone has a lot of effects throughout the body. And if we cut down on that blood in our blood supply, then in turn, yes, it could reduce our blood pressure, but we could also have higher levels of potassium. Potassium could be devastating because at very high levels it can be fatal. But so we have to take this under close consideration and close watch as we're kind of going all through the other things that we can to improve our health. Blood pressure, as we call it, high blood pressure is the silent killer, because there may not be any immediate effects of symptoms of having high blood pressure. So that's why we do have to pay particular close attention to not only these electrolytes like potassium and the blood pressure numbers themselves, but continued monitoring for any other side effects that may come up. So that's what it's going to take close watch with, as you mentioned earlier, primary care doctors, family doctors, internal medicine doctors, all of those at the front line.
We're going to go to another topic, and Dr. Hessler, we're going to point this one at you. Our friends at the BBC did a nice story about choline. They called it the brain-boosting nutrient you might be missing. They describe it as an essential nutrient that supports brain function, especially memory and cognitive processing. Although it's found in foods like egg and liver, for those of you who eat liver, many people, particularly pregnant women and vegetarians, might not get enough. So why aren't more people talking about it? Dr. Hessler, let's start out with a simple one. What exactly is choline, and how does it relate to brain health?
Sure. So choline's not a vitamin or a mineral. It's an organic compound that's necessary for healthy functioning of the nervous system. And we typically get it for our diets, but like you, Joe, I'm not a huge liver eater.
No,
I do like eggs, but
yes,
not necessarily liver. So, again, I guess, kind of some of those people that could be vulnerable.
got it. Who's most, I mentioned potential people who might be vulnerable, but who's most at risk for choline deficiency, and how could they get enough through diet or supplements?
So it's kind of interesting in this article that that only 11% of Americans the typical American diet consume enough choline. And really, I think most of us think of eggs as a source for choline, as you mentioned. So, if somebody has a restrictive diet, and there's all types of restricted diet for a variety of different reasons, but particularly a vegan diet where you're not having any animal products in one's diet, they could definitely be at risk for not getting this in their diet. So it was interesting in reading this that without eating eggs or taking a supplement, it's extremely difficult to get an adequate amount of choline. So just as an example, and now that, we've all been talking about eggs and the price of eggs, apparently the Easter thing to do was to dye marshmallows instead of eggs because of how expensive eggs were. I just heard the other day. So one egg has about 155 milligrams of choline. And if you look at the NIH website, it's recommended that the amount of choline in one's diet that we should get daily in a male is about 420 milligrams. I'm sorry, that's a female, about 420 milligrams, whereas a male is 550 milligrams. And for a pregnant female, it's a little higher at 450 milligrams. So you need to eat more than one egg, but egg is definitely a source. But, to your question, really, that restrictive diet is where people might be missing out on this compound from their diet.
Should we expect to hear a little bit more about choline as part of nutritional guidelines in the future?
I think we could, and it's something interesting to think about. And there definitely are. I looked up online. There are choline supplements. Each has about 330 milligrams of choline. But, kind of that diet that does incorporate eggs or animal proteins, people are getting it from their diets. So I think it could be something to keep our eyes on in the future of, again, I guess to the thought of on my 2 questions you've asked me thus far is, of our brain health. We want to keep those brains, as a neurologist, you and I value keeping those brains functional as we age.
Absolutely. We're going to stay on the theme of aging. And Dr. Ivory, we're going to kind of go on an interesting trend. Amid growing evidence of slowing rates in the fertility rates in the United States, a new report contained a pair of surprising details from 2 divergent age groups. A growing number of women older than 40 are having children, and a record low number of teenagers are giving birth. The report was released earlier this month by the National Center for Health Statistics that showed that the U.S. fertility rate, the average number of children born to a woman during her reproductive years, has continued its decade-long slide through 2023, with American women having an average of 1.62 children compared to 1.66 in 2021 and 2022. So, Dr. Ivory, we're seeing more women over 40 having children and fewer teens giving birth. What does this shift mean for how we approach prenatal care, given it's more older moms as opposed to younger ones?
Dr. Joe, this is so funny because, the running joke out in the community is that I feel attacked because I was 40 when I had my only child. Right. But anyway.
I have nothing to respond to that, but I hear you.
But what does it mean to prenatal care? So there are 2 things. When we talk about an individual patient who's coming in the very late 30s and 40s pregnant, then they come with a higher percentage of comorbidity. So on the clinical side in direct care, we really need to pay attention to the higher risks associated with a pregnancy that is also associated with chronic hypertension. That may also be associated with type 2 diabetes that predates the pregnancy. We talk about thyroid disease. We talk about even the effects of obesity. So having an acute awareness that the risks are higher, not just on the notion of trisomies and other birth defects and mutations that we could actually test for. But the comorbidities of life and other diseases that can complicate pregnancy at the prenatal care stage or pregnancy during labor and delivery, during the actual delivery. So those things are important, and they do increase costs, but those numbers are not necessarily higher than our younger ladies in terms of the decrease coming from teen pregnancy.
So with fertility rates falling, and I'm wondering what you remember hearing from patients who are concerned about waiting too long to start a family. I mean, how did you guide them when they brought in that concern?
You know, it's funny. It was less patients coming in with the concern more than me putting the concern in their head, putting the thought in their head in their mid-20s. One of my professors always said, and she was an infertility specialist, and she was just like, you know, we're doing our young ladies a disservice by making them believe that you can have everything. We can have everything, we just can't have it all at the same time.
Yeah.
And that was really the mantra I gave to my patients. When they were in their mid-20s, I said, you need to make a plan, because waiting until you're 35 to start thinking about, am I going to have a baby, is putting yourself behind the 8 ball. Fertility changes once you hit 30. And there's some slight change and decrease in fertility, spontaneous fertility in your early 30s, but by mid-30s and certainly late 30s, we see an appreciable amount of infertility that is ovarian related, that is ovulatory related. And that's because of aging in the ovaries. And that's not fixable for the most part. IVF and assisted reproductive technologies are important, and they're a wonderful tool. A lot of women feel that they can delay as long as they want by freezing their eggs, but I reminded young ladies all the time that the fertility you were born with is free and readily available. And so you need to have a plan. And if plan A isn't working out by 30, then I want you to be ready to talk about when plan B needs to be activated. So that's the kind of what I did with patients. The ones concerned usually came in late 30s because they hadn't gotten pregnant easily. And that's a different ballgame.
Dr. Ivory, I'm going to ask you kind of a somewhat philosophical question. When you hear these type of headlines about fertility rates and different groups declining birth on one, more births on the other, are these trends, are they simply a reflection of just greater reproductive freedom and planning? Or is there something else going on, systemic barriers or pressures that we should be highlighting that are really reshaping the decision on when and whether to have kids?
It's really both. It's politics, it's community, it's socialization in terms of what do we expect, what do we want, and in terms of women, and to what degree will women have agency to control their own fertility. The decrease, and especially in the teen population, is exactly what we aim to do, is to prevent teenagers from getting pregnant, because they don't plan. They're just randomly getting pregnant for the most part. They're mistakenly getting pregnant and reducing the risk of continuing to have a rate of 50% of pregnancies being unintentional.
Yeah.
Some of that had to do with the teenagers. So we have been wildly successful, especially with long-acting contraceptives, in terms of preventing our young girls from getting pregnant as teens. Now we need to talk about being in a political climate that does not really support women working and women having it all. There's a balance to be struck, and we can strike that balance without women losing rights. So that's really my philosophy about it. Yes, barriers are going up now that weren't there before. Pressures are coming from different directions, but we achieved what we had hoped to achieve, which is preventing teen pregnancy. And so that's why we see the skew in the numbers now.
Interesting. Up next, our experts answer your questions. And we'll be right back.
Did I get a letter? Did I get a postcard? Woo, Mr. Postman.
Hey, it's Dr. Joe Servin. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media. Welcome back. I'm Dr. Joe Servin, and this is What's Health Got to Do with It. Our producer, Stacey Bennett, joins us now with questions for our experts from our listeners. And in the spirit of April Fool's Day, some of our listeners got a little cheeky with their questions this month. Now it's up to our experts to keep a little straight face, that includes both of us here, and still give us the answers we need to know. Stacey, good to see you.
Hello, Dr. Joe. How are you?
I am good. I am ready. Why don't you start us off with the first question?
Well, this one comes from Treading Lightly in Tampa.
Oh, dear.
Treading Lightly says, my partner is considering a water birth, and I want to be supportive, but I have questions. Mainly, am I supposed to be in the tub, near the tub, or just handing out towels like an overly emotional support lifeguard? Is this serene spa-like experience real, or am I about to witness a scene straight out of Shark Week?
Wow. Dr. Ivory, I don't have experience with water births, and so I'm going to refrain from adjectives like Shark Week. But why don't you help answer that question to Treading Lightly in Tampa?
Oh, Treading Lightly, you clearly do not know what's ahead of you. Shark Week is the cartoon trailer before the main feature, I promise you. So,
wow.
Do not get in the tub. Keep the net ready to be fishing out the things that are going to be floating up in the tub that are not the baby. And feel free to hand out towels and hand sanitizer and everything else. I'm not against water birth. Okay, I lie. I am against water birth, but the comfort during labor is fine. Delivering underwater, boy, you're going to really see some things floating around that you're not really used to swimming around in. And I just, newborn baby swimming around and all that is what it is. Just do your homework, watch a video of a birth, not in the water, and get prepared before you get there, because you're going to get overwhelmed otherwise. This is not a serene spa-like experience.
We'll take it from there. We're all educated. Stacey, what else do we have?
Cynthia in Chicago. This is a weird question.
Okay.
So many people see their doctor via telemedicine. I'm wondering if you find the backgrounds from where patients are seeing their doctors distracting. For example, my mom did a telemed appointment from an airport women's bathroom. I was horrified, but I could not stop her. The doctor seemed oblivious. Are there studies that have looked at the optimal place to conduct such visits?
Dr. Knight, I don't know what to say about Cynthia's mother, but I will confess to having done a personal telemed appointment from a Delta club in an airport in the U.S. behind a fern. But
well,
go ahead.
I do love a weird question. This is a good one. And talking about has it been studied? I mean, and maybe we just need to have a separate journal of publication of weird medical studies, so it fit right in. But I think it's good. This telemedicine thing is all new to us since the pandemic, so we don't really know what the expectations are. Is it distracting? I mean, yeah, a little bit. I mean, but not. It shouldn't take away from the point of the visit. I mean, is it distracting if someone comes in a really loud outfit into the exam room, or too much perfume or whatever? It's like we just try to use what it's at our before us that we can help with the medical question or need at a time. So it can be, but I mean, I think for everyone's best interest, it's always better to try to be least distracting as possible, just to kind of get to the purpose of the visit, right?
I love it. Stacy, let's go for another one.
Walking on eggshells in El Paso. My wife may be menopausal. Is there a safe way to ask my wife, how are you feeling, without accidentally triggering a TED Talk, a tearful monologue, or a restraining order?
Oh, goodness.
Just looking for survival tips and maybe a script.
Dr. Ivory, help out walking on eggshells in El Paso, Texas for us.
Humpty Dumpty.
Oh, walking on eggshells. Menopause is my wheelhouse. So, what is my advice to you? You send in the dog.
Pardon?
Okay? That's what you need to know. You send in the dog. If the dog won't go to your wife, then you don't need to go to your wife either. Because, the dog is just going to take all kinds of abuse. But if the dog is afraid of your wife, then let it go. You already know the drill. Let it go. Go do some laundry. Go clean up the clothes. Go clean up the bathroom. Do something that will take stress off of her plate. And you are far less likely to get a tearful monologue or need a restraining order. Survival tips are all about decreasing her stress, not touching the thermostat. Go put on your winter clothes and stop complaining and ride it out. That's my advice.
I'm just wondering if this would work with cats, Dr. Ivory. I just don't want any phone calls from vets or anything.
No. You send the dog in. You're not, because if the dog is not willing to go and, who greets you when you come home? The dog is going to run out to you. If you come home and I tell my patients this, if your dog is not running to greet you, you need to come back in here so I can help you out, because you're being a bear at home. Everybody else at home, no one else at home can ask that question. That's why you send in the dog.
I love your advice here. That's going to stay with me for the rest of my career. Thank you. Stacy, take us to the next question.
Helpless in Harrisburg. My girlfriend's migraine calendar seems to sync with the moon, Mercury retrograde, and my libido's poor timing. Is there anything I can do to help, or should I just dim the lights, bring chocolate, and back away slowly?
Dr. Hessler, we're getting a theme in these questions, but the folks in Helpless in Harrisburg seems to need your help as a headache physician in this case.
Okay, I just can't stop laughing about send in the dogs. Like, I just, Dr. Ivory, like, that's going to stay with me forever. Send in the dogs, and if the dogs don't greet you. So, okay, to my question, good gosh. So I would tell this Helpless in Harrisburg to have patience with his girlfriend, especially if he values the relationship more than the libido and all these other things. Bringing the chocolates, dimming the lights, that's always a good thing. But yes, back away slowly is probably a good thing, because it's, migraine is a disabling disease, and it's not just about the headaches. There's multiple phases of migraine. You have the prodrome, the aura, the actual head pain, and then the postdrome. So, if she values that relationship, I would offer patience to our friend in Harrisburg.
Good advice. Stacy, I'm afraid to ask, but what's the next question?
These names are so interesting. Pressed for time and biceps in Tallahassee.
Okay.
As a newly minted working adult, I've discovered a harsh truth. Grown-up life isn't exactly gym-friendly. The The days of spending 2 to 3 glorious hours flexing, sweating, and pretending I knew how to stretch properly are over. Now I've got about an hour a day if I'm lucky, and I want to make it count. If my goals are to stay healthy and feel good, and maybe look decent in a t-shirt, how should I split that time between cardio, weights, stretching, and core work? I know no routine is perfect, but I'd love the expert cheat sheet before I end up calling it a day.
Dr. Knight, we want to help our friend in Tallahassee look good in that t-shirt. What's your recommendation for
Oh
the
my
exercise
goodness.
exercise regimen?
Yeah, we gotta look good in the t-shirt,
Right.
hands down, no questions asked. But oh yeah, totally sympathize. I mean, grown-up life isn't exactly what we had in mind, whether it's gym friendly or anything else. But I should commend is it Press for Time and Biceps in Tallahassee. Yeah, good kudos to you for even making the effort to get the time in your day to exercise. And so I think probably more people get hung up on the fact that that they are limited what they can do, so they end up just not getting anything at all. And actually more of the studies have shown recently that some exercise is not like a minimum amount that you need to get. So some exercise is definitely better than nothing. So really just get what you can. What fits in your schedule, and what feels comfortable to you. I mean, yeah, you have more time and on hands that you can kind of get into splitting it up between cardio, weights, and stretching and whatnot. But I mean, at least get something in, just something you feel comfortable that it brings you good health. And we were talking about high blood pressure earlier. And so this is a great way to bring down blood pressure. And I know you've got some very astute listeners too, so I have to correct myself. The top number you're looking at, these have changed now, is actually 130 on that top number, which is what we're going to say is the cutoff for hypertension. So if this is your routine and gym life is going to get you down to that range, and you can stave off any of these needs for medications, then yes, excellent. Get whatever you can, and if you look good in that t-shirt while you're doing it, even better.
I love it. Stacy, what's next?
Hot and bothered in Boca. How do I know if it's perimenopause or if my family is just more annoying than usual? Is there a test, or do I just need to apologize less and blame hormones more?
Dr. Ivory, I don't think it's going to be sending the dog on this one, but how are you going to help out our hot and bothered person in Boca?
Well, hot and bothered, it's important to know that your family is more annoying, but when your estrogen levels are decreasing, you're less tolerant. So it's really kind of both things. So when we talk about a test isn't really helpful unless the levels are really abnormal. So if your FSH and LH levels are really high and your estradiol levels and anti-Mullerian hormone levels are really low, then that will rule in menopause. But if those levels are more normal, it doesn't mean that you're not perimenopausal. Doesn't rule it out. So never apologize. That's menopause rule number one. Never apologize. You're the one going through it. They will deal with it. Hormones, yes, they can be to blame. Stress can be to blame. Not being clear on what's happening with you can be to blame. All of those things can occur. So you take stock of where you're at symptom-wise. Make some decisions that are not going to disrupt your family or really break relationships in a more permanent manner. And understand that perimenopause is a marathon, not a sprint. And so address the symptoms, work with your family because you love them and they love you, and this will pass.
I'm going to remember, don't apologize. That's such great advice on this one. Stacy, our next question.
Hormones and headaches in Houston
Okay.
asks, why does my brain act like it's allergic to my menstrual cycle? I swear it's less of a headache and more of a monthly brain rebellion with a soundtrack and everything. Is there a neurologist-approved peace treaty?
Dr. Hessler, here's another great moniker, hormones and headache in Houston. Help us out.
All right, Joe. So I think this is a great take right after Dr. Ivory talked about perimenopause, because there are hormone fluctuations that happen, and women that are prone to menstrual migraines, that drop in the estrogen level right before a woman has her menses, is when a woman could be vulnerable to having menstrual migraines. So I know this, our listener in Houston's talking about less of a headache and my monthly brain's revolt or rebellion. So it's also similar in some ways that you're having those hormone fluctuations, during this time. So unfortunately, I don't have a neurologist stamped peace treaty. I wish I did. I'd have people lining up around the block to see me. But, I think, as I said earlier, I think, during that time is, when it feels like you're not able to remember things or concentrate, in addition to potentially having a menstrual migraine, it's important to be kinder to oneself during this time, during that stressful time of month. If it feels like the brain is on rebellion, I think that's probably, so working on those things, such as maybe, going out for that brisk walk, eating, those, a better diet, working on one's sleep, all those lifestyle things can really help kind of calm the brain and put the brain in a better state.
We'll let that be our final word. I want to thank our incredible list of experts. Dr. Donna G. Ivory, she is an OBGYN here in the Jacksonville area. Dr. Amy Hessler, a neurologist also in the Jacksonville, Florida area. And Dr. Dacre Knight, a practicing internist, head of the Ehlers-Danlos Clinic at Mayo Clinic in Florida. Thank you so much for your incredible wisdom and insights today.
Thanks, Joe. Fantastic show.
Appreciate it.
You betcha. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at WJCT.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Luckin. Stacey Bennett is our producer. Brady Coram is our director. Caden Collins and Caroline Kahn are our researchers. If you have any questions about this or any topic, let us know by calling us at 904-358-6362. Email us at health@wjct.org or tag us on X, Threads, Blue Sky, Facebook, LinkedIn, or any social media at jservin. I'm Dr. Joe Servin, and you're listening to What's Health Got to Do With It on WJCT News 89.9 Jacksonville. Thank you for listening, and stay in touch.
Support for What's Health Got to Do With It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.